So my name is David Sarraf. I'm a retina specialist at the Stein Eye Institute at UCLA. EIDON UWF asked me to give a talk on a particular retinal entity that I thought would be appropriate with multimodal imaging. And one area that we have a great interest in is vitelliform dystrophies and vitelliform maculopathy. There have been many vitelliform disorders that have been described over the years. Some you would be very familiar with, such as Best disease. But over the past several years, through the benefit of all the advanced retinal imaging that we have available, including these wonderful color fundus cameras, we've been able to study some newer vitelliform dystrophies. Shouldn't use the word dystrophy, they're more acquired lesions that do not have necessarily a genetic etiology. And I thought what I would do today is review some of these newer vitelliform maculopathies that we've described recently, in addition to maybe providing some overview of vitelliform lesions in general. So we'll start off actually with this case. I want to acknowledge we have a whole army of fellows that help with all our projects and all our patient care and procuring all the beautiful images that we present at various meetings, and I wanted to acknowledge their contribution to this talk. So this was actually a male patient who presented with a vitelliform lesion centrally in both eyes, and we were unsure of the etiology, why he had the vitelliform lesions. Generally, when you see a vitelliform lesion, it's an indicator that the RPE is impaired, the function is impaired, and normally the RPE turns over shed outer segments, and if those outer segments are not being properly phagocytosed, they accumulate in the subretinal space as this yellowish vitelliform material that can light up on autofluorescence. And this particular gentleman presented with some vision impairment, and what we saw in the OCT were these classic vitelliform lesions where you see this kind of dome-shaped hyperreflective lesion in the subretinal space. And as I mentioned, it's an indicator of RPE function impairment. But he was a little bit older. He didn't have any layering or family history to suggest Best disease, which is the most common cause of genetically acquired vitelliform dystrophy. And here you can see on the autofluorescence how these vitelliform lesions, they emit hyperautofluorescence. And so they appear bright on the autofluorescent image. And this is a wide field near infrared autofluorescence, where again you can see these bright hyperautofluorescent lesions that I showed you on the OCT. They seem to be affecting his vision. A relatively otherwise normal patient in terms of his eye status was seeing 20/40. These are the EIDON images, and I thought they were quite impressive. They show you the vitelliform lesions very nicely. But what was very interesting in this patient, and I hadn't seen them when we took these images, my fellow was able to look at the images. Does anyone see what the disturbance is here that may be causing the vitelliform lesions? So do you guys see this? Those are angioid streaks. So I actually didn't see them when I examined the patient, but my fellow was able to capture them with the EIDON image. And by looking at these images, we were able to see that the etiology of the vitelliform lesions was related to angioid streaks. And in fact, this was a stimulus or the motivation to do a study of patients with angioid streaks. The most common condition systemic condition associated with angioid streaks is pseudoxanthoma elasticum. And we tested this patient for various causes of vitelliform lesions and angioid streaks, and you can see the yellow dotted line is highlighting the angioid streaks around the disc, and it all came back negative. But 2/3 of patients with angioid streaks have ABC6 mutation, which is a PXE, and that's an important systemic disease to identify because of all the systemic complications associated with it, including gastric, CNS bleeding, coronary artery disease, and of course skin changes that these patients can have. But in his case, it all came back negative, and we attributed the angioid streaks to an idiopathic condition. We actually decided to look into all our patients as a multi-center trial across the world to see how many of patients with angioid streaks had vitelliform lesions, and it's actually not that uncommon a finding. And we were able to capture 15 patients from various centers in Europe, the Far East, and in the US. 2/3 of the patients had PXE, 1/3 of the patients had idiopathic angioid streaks. And presumably what's happening, the angioid streaks are, again, a sign of an abnormal Brooks membrane, perhaps a calcific elastin component of the Brooks membrane, and this leads to RPE impairment, and then that leads to this deficiency in phagocytic function, causing the vitelliform material to accumulate. We did some other analysis. We looked at how many of these patients developed atrophy. As you would expect with RPE impairment, 2/3 of the patients eventually went on to a form of atrophy, GA, or what we refer to as CROR, a complete RPE and outer retinal atrophy, which is an OCT correlate of geographic atrophy. And 1/4 of the patients, another sign of RPE disease is choroidal neovascularization. 1/4 of these patients with vitelliform lesions also went on to develop choroidal neovascularization. So when you see vitelliform lesions, don't just think Best disease. Look at the disc and see if the patients have any evidence of angioid streak. This was another patient taken from our series. This patient was actually from Portugal, which was another recruiting center. And you can see the beautiful angioid streaks on this montage, EIDON color photograph. And this patient also had comet lesions. You can see these white lesions with streaks. And that's a very characteristic feature of pseudoxanthoma elasticum. You can tell that the patient has pseudoxanthoma elasticum because he has the characteristic wrinkly skin in the intertriginous areas. And you can see the vitelliform lesions here that are lighting up on autofluorescence. So this was another patient who had angioid streaks, but in this case from PXE, that also had the vitelliform lesions. Again, showing the angioid streaks and the comet sign that you see with pseudoxanthoma elasticum. Very rarely you can see patients with angioid streaks due to this very uncommon disease, A-beta lipoproteinemia, which is associated with a significant anemia due to this genetic mutation. None of our patients had this disease because it's so rare, but they can get the RPE atrophy in association with the angioid streaks. This was another patient we had, again, beautifully capturing. This is the same patient that I showed you at baseline, showing the vitelliform lesions, the angioid streaks. We've been following this patient now for many months, 2 to 3 years. The vitelliform lesions have now evolved into these this maculopathy with pigmentary changes. And on the en-face OCT, you can see the evolution of the vitelliform lesion both on en-face and B-scan. And you can see that the vitelliform lesion is beginning to break down. And that's not an unusual manifestation of these vitelliform lesions. They can become liquefied, or they can also be associated with scarring or RPE atrophy, which I told you is present in 2/3 of our patients. And here is the patient. Again, you can see the evolution of the vitelliform lesion and then kind of liquefaction, which is a very common outcome of vitelliform lesions. And this is in the other eye. This patient also had neovascularization. You can see that there right at the disc margin. And the question was, is that neovascularization driving the fluid? We didn't think so. We thought the fluid was a consequence of the vitelliform lesion, but we had injected anti-VEGF. There was no change as we suspected, and now we've decided to stop the anti-VEGF injections, even though he does have peripapillary neovascularization. And then again, you can see the lesion, that kind of RPE scarring that developed, and then a more prominent neovascularization there that you can see with that OCTA. As I mentioned, we've published various papers, some new entities of vitelliform maculopathy. Another new entity associated with vitelliform maculopathy that we've published is referred to as pachyvitelliform maculopathy. And I just want to talk to you about this because this is a very common entity that you'll see, not at all a rare presentation, but a very common presentation in older patients that you may see in conjunction with your AMD patients. And so these are the kind of more classic causes of vitelliform diseases. As I mentioned, the most common genetic cause is Best disease, but PRPH2, which is pattern dystrophy, and IMPG1 and 2 can also genetically cause vitelliform dystrophies, more typically in younger patients. You can see traction, like in ERMs, cause tiny vitelliform lesions because, again, the traction disrupts RPE turnover of the outer segments. Certain medicines can also cause vitelliform lesions, including the MEK inhibitors or the checkpoint inhibitors. And you can see it atop large drusen. So when drusen get really big, the RPE is separated from the choroid. The RPE breaks down, especially at the apex, and you can get overlying vitelliform lesions as the RPE becomes impaired. We also see them with pseudodrusen related to choriocapillaris impairment. But maybe most common of all these is this entity pachyvitelliform maculopathy. And I want to talk to you about that. So these are patients that come in, they typically will have a vitelliform lesion. It's usually asymmetric or unilateral. They'll be elderly in their 60s, 70s, or 80s. They'll have a very thick choroid for their age, typically over 300 microns. And then the classic vitelliform lesion in the macula or surrounding the fovea. And often the lesion can remain stable for many years, or it can evolve to atrophy. As you would expect, it lights up on the autofluorescence. So in addition to seeing these lesions over large drusen, sometimes you'll see them just with a pachychoroid and no evidence of AMD or drusen at all. And as I say, it's a very common presentation in older patients. This is a patient actually whose mom and aunt had macular degeneration, but he had classic findings of pachyvitelliform maculopathy. Look how thick his choroid is. That was asymmetric. He had no lesion in the left eye, and you can see the evolution of the vitelliform lesion over time. So whenever you see a vitelliform lesion, and especially in an older patient that's asymmetric, no family history, think about pachychoroid as being the etiology. And another modality that you can use to help with the diagnosis is ICGA to look for choroidal hyperpermeability. I want to finish by telling you about this very interesting case. If you look at the top panel, this was 5 years ago. A 77-year-old patient came into our clinic, and he had a vitelliform lesion in the left eye with some evidence of RPE breakdown. You can see the plume of hyperreflective foci. He was 77, and he didn't relay any family history to us of Best disease or pattern dystrophy. It was very asymmetric, and he had a very thick choroid. Keep in mind, this is an 80-year-old, and his choroid is over 300. Typically, 80-year-old patients have choroids of 150, not 300. And so we said, okay, this must be pachyvitelliform maculopathy. We'll just monitor him. But as he came in, look what happens. The lesion gets bigger and bigger and bigger, which is kind of, in both eyes, which is kind of unusual for pachyvitelliform maculopathy. Usually the lesions will stabilize or they'll resorb and progress to atrophy. When we saw this, we got this EIDON photo, and the EIDON color photograph shows layering in this 80-year-old patient. So what do you think he has? We genetically screened him, and what came back positive? So this was an 80-year-old guy who came back with Best disease, and when we questioned him more carefully, he actually had a cousin with Best disease. So we labeled him as pachyvitelliform maculopathy, the new entity, but in the end, he had the classic entity at the age of 80, very unusual. Most Best patients you'll see in their 10, 20, 30, certainly under the age of 50. To see them over at the age of 80 is very unusual. And this is the evolution of his vitelliform lesions. We also tested him for paraneoplastic disease, because paraneoplastic disease can also impair the RPE through specialized antibodies leading to vitelliform lesions. But systemically, he was normal, and the Best gene came back positive. I'll show you. This is, again, just showing the sequence on OCT, the beautiful vitelliform lesions with that hypopion in this 82-year-old patient. And I don't show you the genetics, but the genetics came back positive for Best 1. This is one final entity that I'll show you with another new entity with vitelliform lesions. This is what we refer to as multifocal vitelliform paravascular retinopathy. So these patients are very particular, very unique vitelliform patients because their vitelliform lesions are exclusively around the arcades in the region of the blood vessels. This is our resident who put all these cases together from all around the world. And what you can see is this really spectacular pattern of vitelliform lesions around the arcades. Several of our patients were tested and none of them were BEST positive or positive for any of the other genes like PRPH2 or IMPG. And you can see how beautifully they light up on the autofluorescence. They're typically hyper-reflective, but some of the lesions can become hypo-reflective. Remember that liquefaction process that I talked to you. And altogether, we had 15 patients. Half the patients were actually African or of African descent, and they were typically younger. The lesions can increase in number, but typically they don't affect vision. And patients typically have excellent vision, as you can see by the mean of 20/30 that was maintained pretty much through the follow-up. And these are all the patients, and you can see that characteristic paravascular predilection, which is very typical and unique of this disease. So think about MVPR as another cause of a novel vitelliform retinopathy. And I think that's it. I appreciate all of you listening.